Hello, and welcome back to the Intent Medical Group podcast. I'm Dr. Sammy Khalili, and I'll be your guide as we explore the stories, breakthroughs, and people behind exceptional care across our team. If you're new here, we're so glad you're joining us. And to our returning listeners, welcome back. Today, I'm excited to introduce Dr. Julianne Hall, one of our neurologists and neurointensivists here at IMG. Dr. Julianne Hall is an expert in stroke and critical neurologic illnesses, and I'm so excited for you all to meet her. Let's get into it. Julianne, my dear, welcome to our podcast here.
Thank you. I'm excited to be here.
I cannot be more excited to have you here. Like, this is our new space. We've been trialing it out with everybody.
I love it.
Yeah.
It's beautiful.
It's definitely a lot better than where we were before. I'm glad that you didn't have to experience that.
I did.
But it's been really, really good. Now, for everyone else who doesn't know you, you are a neurologist and a neurointensivist, as that's the official titles. Mm-hmm. But for people who don't know what those things mean, neurology means you are an expert, and you correct me if I'm wrong, in all things of the brain, spinal column, and the nerves of the body. Mm-hmm. And you manage not necessarily as much outpatient things, but things that go on within the hospital themselves, so people who have to be admitted with these problems.
Correct.
And your real specialization, well, in addition to that, the big specialization that you really do is all the people in critical care, the ones who are in the ICU or the intensive care unit.
Yeah, in the neurocritical care unit.
Yeah, so that's amazing. You know, me as an ENT, I'm always fascinated by all my friends in neurology like yourself. In like, how did you get there? Like, what was the trajectory, the journey that led you to decide, say, I want to be in this area, in this field, and not say choose something different? How was it that you ended up in medicine? How did you get started that way?
Oh my goodness. So I had not really planned on going to college initially when I came out of high school, which it was, I'm sure, my parents' dream. And I decided to move to California and just do odd jobs and experience life. And I had a wonderful time for a couple of years, just kind of figuring life out, which I'm actually really glad happened.
Probably gave you a lot of growth, right?
It gave me a lot of experience. I did a lot of really odd jobs.
Okay. Any cool thing or weird thing you want to?
I mean, cool. I don't know if it was necessarily cool, but I worked in like a tools warehouse where I was like putting together sockets and things. And I don't know anything about tools, but I was doing things like that and waitressing a lot and doing things. But when I started dating my husband, so I have to say he gets credit for this. He encouraged me to go to college.
That's awesome.
He was like, you should probably go to school. And I'm like, oh, okay. And then once I started going back to school, I realized and I remembered how much I loved learning and how much I enjoyed it. So then I was all in. But I had no interest in medicine. And that's mostly because I was always afraid of needles. And I couldn't get my blood drawn without fainting.
Yeah. No.
So you would never guess.
Believe it or not, Julianne, I had the same problem.
Really?
Yeah, no, I did. And I'm a surgeon now. And that happened. My dad always remembers it because when I was 4 years old, he remembers one nurse was quite rough with me. And ever since that moment, I was classically conditioned, meaning that like anytime I would come close to the hospital, I was worried the same event was about to happen.
Absolutely.
So it took a while for me to kind of get away from that fear and just work through it to say, like, that's not, it's more conditioning, not actually reality. But I appreciate what you're saying 100%.
Yeah, definitely. So there is the conditioning there. And I realized, I came into medicine actually through psychology because I was really interested in, I'm just fascinated by things in psychology and psychiatry. And I kind of found my way into a niche where it was, I was working with adolescents with eating disorders.
Wow. And
working with one of the biggest names in that field in the treatment for those conditions. And it was something that actually worked well, which is very rare to find in that world. And they were these are young people that have really long, amazing lives that they could have ahead of them. And so to me, that was amazing. Like, helping these young people to be able to be well again. And so I did a lot of research. Yeah.
That's a very tough thing to witness and watch. And it takes a special personality to be able to even do that. So I commend you for that, for sure. That's amazing.
It's definitely a difficult population, but they're very smart individuals, and they're really just wonderful people.
Wow. Yeah, I'm sure you were, and I'm sure you did wonderful with them. So then you work with them, and then kind of what happened?
I got involved in research.
Okay.
So that's kind of where I started doing research in that work. And then I feel like most things in my life came to me where like by happenstance, but it just worked out, and then I went with that path. Mm-hmm. So I really do believe that life just kind of rolls out in front of you, and you just kind of need to take the path that is for you, like what you're meant to do.
Yeah.
And that's what happened. So I was at UIC, University of Illinois at Chicago. That's where I was getting my degree, and somebody had approached me and told me, "Oh, you should apply for a Fulbright scholarship." And other people do know what that is, but I didn't know what it was at the time. So I applied and I got one. And
That's
so
fantastic.
Then I did a year abroad in Toronto, actually, at the Hospital for Sick Children, working on
kids. Yeah.
DSM-5 criteria. Yeah, it's sick kids, because that's the best name for a
For
children's
a children's
hospital.
hospital, sick kids. I know.
Yes.
You would think they could be a little more creative. I know, but that's amazing. The Fulbright scholarship that's a very prestigious thing. That's I know you're saying you didn't know, but that's amazing. That's a comment to your prowess, like, and that's very humbling of you. You're not even to recognize, not even to know how big that was. That's amazing.
Well, I don't talk about it very often, so most people don't know that about me. But it was a really cool experience, and because of those research experience I had, I was able to work on multidisciplinary teams with physicians and see all the different roles on those teams, and they let me shadow them because they were so kind. And so I shadowed in bariatric surgery, and I was like, that's really cool, because I was doing their classes for like preparation from the psychology side of all the changes you have to make in order to be able to deal with having a totally new
digestive system. Yeah.
Right.
Yeah.
So when I was in surgery, I was like, I can do this. Like, I can handle this. This is really cool.
Yeah.
And I realized that it wasn't the needles and the blood as much. I don't like seeing people in pain. So when I can see that they're in pain, that is hard for me. So when they're out and asleep, everything's fine, and it's just really cool. So it's something I had to learn.
Wow.
along the way.
That's very interesting. Okay. That's an interesting thing to discover about yourself as you go through it. So then now it kind of makes sense how eventually you end up in the ICU. But so at this point in time, you hadn't applied for medicine yet, had you?
No.
Yeah.
No, I had to actually go back and do like all of my pre-med, because I had done none of a pre-med before. So I did that, and then came to medicine. And I thought initially, of course, I'm going to be a psychiatrist because I'd come from psychology. But I actually found neurology through my love of psychology and psychiatry, because there's a lot of overlap and things.
There is, yeah.
Like our boards are through the same, I don't know what you would call them.
Are they the same?
ABPN,
But your board, if I'm not mistaken, I could be wrong, your boards are the same, right? So you write the same exam together. Or am I wrong in that?
It is the same, but it's like, I'm pretty sure the way that they do it is their exam has more of a skew to psychiatry, and ours more towards neurology. So the questions are, mostly neurology and some psychiatry versus mostly psychiatry and some neurology.
Got it. That makes sense.
Yeah. But when I did my neurology rotation, I found like interesting things within neurology that kind of overlapped. And then one day I saw a patient who was able to get a thrombectomy, who had a massive stroke. And they had a thrombectomy done. I saw them the next day. I mean,
and for anyone who doesn't know, thrombectomy just means you're removing the clot that caused the stroke to begin with, correct?
Correct. And I'm happy to talk more about these kinds of things in the future, too. So, yeah, we can actually go in and take the clot out. We, not me.
Yeah.
Some of our amazing partners will do that.
Yeah.
Yes. But I saw the patient the day after they were able to go in and take the clot out. And they were normal. They had nothing wrong with them. And their MRI or the images we got of their brain didn't even show any permanent damage. And that was just the coolest thing I had ever seen, like how much of a impact you can have in someone's life, that it sold me.
That's amazing. So with that, you're now in medicine, you're now applying for residency. Now, where did you end up doing both of those things? Did you do them at the University of Chicago or
I was at University of Illinois in Chicago for undergrad.
For undergrad.
Yeah, and then Northwestern for my post-bac.
Nice.
Or like my pre-med stuff.
Yeah.
And then for medical school, I did Rush in Chicago. I did everything in Chicago.
That's awesome. You were able to stay very close, and your husband was with you the whole time as you're going through this?
Yes.
Yeah,
that was a deal breaker for me, to have to do a long distance thing. And thankfully, I live in a place where there are, some amazing places. But yeah, I was at Rush.
That's the wonderful thing about the Chicagoland area. Most people, you can usually find something for everybody in the place, hopefully, typically, and for a lot of people. So then you now are in your residency. You're doing neurology. You've also discovered that you've figured your sweet spot, which is seeing people when they're asleep and dealing with them at that moment in time. That's your kind of like where you feel like the most you're in your groove. So at what point did you say like, oh, ICU, that's where I want to be?
Well, I wouldn't necessarily say I want all my patients
correct.
to be asleep.
I shouldn't phrase it that way. You're right. It comes off as like, oh my God, this sounds crazy. But no. I think you're getting at the point I'm trying to make of how you got there to the intensive care unit. So when did that kind of like manifest? Because now you had seen several different areas, all somewhat connected, but they're not. You're not quite yet in the intensive care unit yet to kind of say this is where I want to hang out.
Yeah, I was all over the place. I liked everything. And part of me not coming to medicine with a medical background or anyone in my family really like that, it made it so that everything was new and exciting for me.
Yeah.
So I was like, oh, I didn't know this existed. I didn't know this was there. So it was kind of cool in that way because I was like, bright-eyed and bushy-tailed, I guess. But I really liked the more high energy things, I guess. It is where I ended up gravitating towards, like things like stroke. And then neurocritical care ended up being the best kind of environment for someone like me who has a shorter attention span, likes to think on my feet. And I have a hard time sitting in clinic. So it worked out well.
That's awesome. So then eventually you came, and we were blessed to find you and kind of have you come and join us over here at IMG. I'm just curious, what made you decide because someone like yourself with everything that you had, all your accolades, the amazing amount of experience you've talked about and just shared with us, you probably could have had your pick of the litter of where you could go, what you could do, what you want to do. What made you decide that you want to come hang out with us over at IMG?
Well,
I think we're awesome. Don't get me wrong.
You oversold me a tiny bit. I feel like I wasn't that amazing by any means, but I did do a lot of research and a lot of academic kind of stuff throughout, residency and things. So most people, myself included, thought that I was going to go into academia. And I decided that I would apply to your guys' group because the location was great for me. And it just seemed like there were cool things happening. I had heard I'd heard things here and there about it. And then when I came for my interview day, I was kind of amazed, and I really felt like I found my people.
That's awesome.
And I don't like I'm not just saying that because like, I don't want anyone to think that I'm trying to butter them up or say anything like in that kind of way, but I really did feel that way. I felt like this is where I'm meant to be.
Well, the feeling is very much mutual. We definitely feel like we've won the lottery with having you on the team, no question. But that's great that you felt that kind of same jive. And also at IMG, it's not like quite anywhere else. You would agree with that, right? It's not a typical place.
Yes. So one of the nice things for me when I was like, oh, I might miss some of this kind of more academic stuff, is that I could do a lot of those kinds of things, but not have a lot of the things that I didn't like as much about that environment. There's a lot of teaching. There were a lot of teaching opportunities that I saw. There were things that I could kind of help build, which I liked. I could do research, and it just seemed like I got the best of both worlds.
Yeah, well, that's awesome. So, I mean, as a person like yourself, as active as you are, what do you do when you're not in the hospital and not in studying for things or becoming a Fulbright scholar or all those kinds of things? What are you doing for yourself in other places? Like what do you and your husband do? Like what's your fun zone besides work?
Well, I have a lot of very different kinds of interests. So, I mean, some of them are pretty standard. Like my husband and I are pretty big foodies. We love to go to like those fancy like prefix menu restaurants for special occasions. Of course, we can't do that every week, but we love to do that. But well, right now it's summer and IndyCar is a big interest of my husband's and now mine.
Yeah.
Now that I have found a driver that I really like, that's kind of taken over part of our summer because we go to races. We went to the Indy 500.
That's amazing. Now, when is that usually, the Indy 500? Because I don't follow it, so I don't know 100%. But was it just passed or is it coming up?
No, it just passed. Memorial Day weekend is when they have it. And one of the cool things is, I mean, it's a huge event.
Yeah.
And I can't remember exactly the number, but like all the stands were filled. It was sold out. And then they also have like an electronic dance music like concert in the middle of the field.
No way.
So then there are all those people there. And it being Memorial Day, they do a whole thing for veterans at the very beginning and this whole tribute and things as part of the tradition. So it's just like an all-American weekend.
That's awesome. That's awesome.
There's something for everyone.
Now, I've heard for these IndyCar races and NASCAR, it's very loud. Is that very true? Aside from the EDM music and everything else going on, is that very true?
Yes, but it depends on the car.
Okay.
And I'm not good enough to know a lot of the details about these things, but I do know that the Indy cars are less loud than some of the other cars that will race on those tracks.
Okay.
However, I do still like to protect my hearing.
Yeah.
And
shout out to me as the ENT in the group. Yeah.
exactly.
Yeah, that's right.
I had to put that in there. Yes.
That's awesome. All right. Cool. So, I know we and I have talked before in terms of things that you love doing and whatnot, and what is your passion at work. Now, you're so wonderful with all the patients, I know, but there's certain things that really, really are a true joy for you that you take at work on a regular basis. Why don't you tell us a little bit about the things that really like motivate you when you see patients and when you deal with their families and all those kinds of stuff?
I love helping patients and families help them get to the decisions that these really, really challenging decisions, these impossible decisions sometimes that they're faced with, involving their loved one or their somebody really close in their life, trying to make decisions that's most in line with what their wishes are and helping them get there. That is really, really satisfying for me. And it just brings me so much joy to be able to like help guide the conversation to try to not have it be what I would do if it were my family member, but what they are telling me would be the best thing for them and helping them get there.
Yeah. A good place for maybe I can help the audience, the people listening, to get there is like at what point they're going to end up and see you. So let's say they have a family member and one of them has a stroke, and they see the things happening at home, and we're going to have lots of time to talk. Well, we can talk about it now. What family member has something that they're worried about that has a stroke? What should they be worried about at that moment in time? Let's start with that before they even get to the hospital. Yeah.
So there are a few things that I wish everyone would know about what to do or what to kind of try to remember in that moment, knowing that it's a chaotic moment, of course.
Right.
If they think that their loved one's having a stroke. So number one is going to be that time is brain. That is going to be number one.
I like that a lot.
Always.
Time is brain.
Yes.
That's important. Okay.
Yes. I mean, I didn't come up with that. That's like a very neurology thing to say.
Yeah.
But it's true. If you
you don't hear it in the ENT circles much, so time is brain. I like it. Okay.
Yeah. So as soon as you know something's wrong, call 911, call the emergency, and usually the medics are going to be the ones that get you to the hospital the fastest. So don't try to get in your car and drive.
Right.
Because there are some interventions for strokes that you can only give within a certain time frame. And I want to be able to do those things for you if you if you're the right patient for it. And so if you get there in the right time, I can do that.
So let's kind of talk about that a little bit. What would be the right time frame? Is it they have to be there in 5 minutes? Do they have to be there in 10 hours? Like, help me out. How do I know is like how fast I should be running?
Yeah. So the two main things that I'm thinking about when I think about time is, one, are they in the window or are in the right time frame to give the clot busting drug is kind of how I describe it to patients and families. A really strong blood thinner that can hopefully help restore blood flow to the area that is being damaged by the stroke. And so you can give that generally it's 4.5 hours from the last known well. And that's that's a term that we use in the stroke world, last known well.
Meaning the last time that they knew that they were A-okay and normal.
Exactly, which is a different time than when somebody found them with their symptoms or whatnot.
Right.
That time is, the symptom discovery or I guess that's what you would call it, symptom discovery.
Yeah.
But the last known well might be the night before when they went to bed and somebody found them the next morning. So you have to go by that time, that earlier time, which makes it so that some people don't qualify for things. However, there are exceptions to that rule, especially with these interventions.
Okay. So I'll get to that and we'll talk about those exceptions in a minute. But so now a family member has found somebody, let's say, or they witnessed it in front of them. So now they know both the last known well and the moment when the symptoms started. They call 911. What should they communicate to the 911 person?
Yeah. So that time is the most important thing for them to get from you.
Okay.
They're going to be asking about blood thinners.
Okay.
That's a really, really important question.
So the common ones, I'll rhyme off what I know, and you tell me there's extras. Warfarin is a common one. That's the old one, or Coumadin, they've called it.
Yes.
Eliquis, Xarelto.
Or Pixaban.
Yeah. Pixaban, that's right. Xarelto is another common one that I deal with a lot. Would you say high-dose aspirin or just aspirin in general?
Aspirin for sure, yeah. Clopidogrel.
That's right. Yep. Or Plavix is what people would call that one.
Yep.
Brilinta, I'm not even sure which one that is. Brilinta, which one is that?
That's it's kind of like
in the same class
aspirin or Plavix,
Gotcha.
In that world.
Okay. So those would be all your blood thinners in that category.
Yeah.
Okay.
So I want to know what blood thinners you're on and when the last dose was.
Okay.
And then I want to know what their normal is.
Yeah.
Because some people have things that have happened in the past that make it so that they're not, they might have weakness at baseline or something else going on. So you have to know what's new and different.
Right. Okay. So now you have that information. You have their list of medications that are bothering, that may have had some influence on the situation. And then what next? Because you're still at home at this stage.
Well, we're talking to the paramedics right now. And we're giving them information. Things are happening all at the same time. Yeah.
Okay.
And then they're going to be, I guess the other thing that can happen at somebody's home, which is a misconception that I did want to make sure I mentioned.
Yeah, of course.
Is that if you think that you're having a stroke or somebody else is having a stroke, you should not take an aspirin. Okay. And that's something that I hear patients say quite often, that they took an aspirin because they thought they were having a stroke before they came in. And it's very intuitive, except for if you come to the hospital and then find out that it's actually a bleed in the head, then that's probably not the best thing to be taking before you.
I wonder if that came from the cardiac teams.
Yes,
is that how they've extrapolated it to say, like, oh, well, for this, if I'm having chest pain, I should take an aspirin.
Yes.
Well, maybe I should do the same thing for this, but that's clearly not okay.
Yeah, it's not what you want to do.
Okay.
So let us give it to you.
That's great.
We'll give it to you if it's appropriate.
Right. So don't take don't take any aspirin if you're worried about a stroke, and tell us, like, what are the features of stroke? I know there's a fancy acronym out there.
Yeah. Well, there are lots of acronyms, but I think there are really common things that a lot of people know would be more of a stroke symptom. So one side of the body is often affected more than the other, or just affected. So weakness on one side of the body, numbness on one side of the body, speech changes, which could be slurring of your words or an inability to get words out or express your language, or an inability to understand language, or both. Vision changes where there's a portion of your vision that's missing. I feel like those ones are things that people can identify easier. But something that I think doesn't get talked about enough is that there are other things that strokes can present with that are less commonly spotted. But the bottom line is, if you think something is off, if you feel like, something's wrong, I don't know what it is, but something's wrong, come seek medical attention. We'll tell you if we need to be worried or not. Let us figure it out.
Right. Time is brain. Come soon. And then that way people like you can come and investigate what's going on quickly so that interventions can take place. So I guess now we'll roll into family members finally got the paramedics, picked them up. They brought them into the hospital. At this point in time, is that when they would end up seeing you, or would they would see someone else first?
So hospitals all kind of have their own system in some ways, but there is a lot of standardization within the stroke world now. We are lucky enough at our institution to be able to be in-house. We have a neurologist, actually a neurointensivist, that is in-house 24 hours a day. That is not something you see very often.
I think we're the only ones in the city that are like this, I think.
Well, yeah.
This last check.
Well, there are other places that have, fellows and residents and people there. But an attending neurocritical care physician, I don't think is as common. I don't know where that might be, or if we are the only ones.
I won't say it definitively to not get ourselves in trouble.
Could be. I don't know.
But I think.
Yeah. So the benefit of that is that I can go meet the ambulance as they come to the bay. And so I'm there, the emergency room doctor is there, we have nurses there, and the medics are there. So we can all talk and hear the information from the medics and examine the patient right there. We're getting an IV right there. We're doing everything at the same time. So it's a little chaotic and
because time is brain.
Exactly.
Yeah.
So I have to get a really good exam in. I have to get as much history as I can within a short time frame so that we can get to the scanner.
Yeah. Okay. So then you do all those things. You, as we say, stabilize the patient as best you can. You got your information. You go to the scanner. Now, what kind of scanner are they usually getting to start with?
So a CAT scan is the bare minimum. Everyone has to have a CAT scan of the brain tissue itself. But we add on also a CT angiogram or a study in the CAT scanner that looks at the blood vessels of the head and neck. And that's to look for any clots that are in any of the major vessels of the brain that we might be able to intervene on.
Okay. That's great. And then, so now you have all that information, and then you're deciding at that moment if the person, I'm assuming, you correct me if I'm wrong, me being the lay ENT, that you're deciding at that moment, is there an active bleed in the brain, or is this potentially a clot that prevented blood from getting to the right place? Would that be the kind of the decision-making point that you're making there?
Yes. And the way that I like to describe it is like plumbing.
Yes. Yeah, that's a great way to describe it. Yeah.
I think of it as like a clogged pipe or a burst pipe.
Okay.
So if there's a clogged pipe, you can't get the water, you can't get the blood to the right place.
That's right.
And so it's kind of starving for nutrition versus a burst pipe where there's blood everywhere.
Yeah.
I guess.
And it can't do anything with it because it's going to the wrong places.
It's going to the wrong place. Yeah, exactly.
Okay. So now, I guess now this brings us circled back to you now have this information. Let's say it's blocked pipe. What do we do?
So if it's a blocked pipe in one of the major arteries of the head, that means that we have more tools potentially at our disposal. And those are the strokes. The biggest strokes, actually, which is kind of a cool thing. The biggest, most serious strokes are the ones that are the best for intervention in terms of what we call thrombectomy, which we had kind of mentioned, but it is where you go in through the wrist or the groin and you kind of snake up. You snake up a wire and you get up to the head and you kind of like suck out the clot.
Yeah. So basically, it's very much exactly like plumbing, like you're describing, like that snake that people use to get the plug out in your bad pipes in your house, and then everything can now start flushing again. Well,
right. Yeah. And not every clot is amenable to that, but it's usually the biggest arteries of the head that we're able to access. So that's when you see the biggest difference in their exam and how they do.
Awesome. So in that time frame for that, let's say they find the clot, they do something. What's this? I guess a lot of people ask, let's say, especially if you're dealing with someone who's older and not sure they want more interventions or things like this. What's the success of all this kind of stuff working and all that kind of stuff?
Ooh, the success of it. So
yeah, I think the question I'm just trying to get at is we talk a lot about, as we've been going through the whole thing, about time being brain. So if, let's say, you happen to have this episode across the street from the hospital, and within 15 minutes, I see that person comes to see you, and you make the decision. You bring them to the CT angio scanner, and then you find out that there is something blocking things off, and then that person gets their thrombectomy, or the clot gets removed. The snake does its job, and what should I hopefully expect in that individual? They should recover, or no? We don't know.
It does depend. A lot of it depends on how much damage had already been done. Even in a short time frame, sometimes a lot of damage could have been done in a short time frame, especially in young patients, because they have really, plump brains, which are nice and healthy, but in some ways makes it harder if they have something wrong in the brain. They don't have a lot of extra room for any swelling, and they haven't developed other kinds of branches from their arteries in order to compensate for ones that have a lot of plaques in them. So sometimes you do unfortunately see more injury in a shorter period of time in those cases. However, many of those cases do well.
Yeah, that's great. So now let's flip the script and say, okay, it's not a blocked vessel, but it's one that's busted open. Then what happens?
So if it's a bleed, when we go to the CAT scanner, I am in the scanner where the radiology techs sit.
Yeah.
And I am looking at the scan as soon as it's done.
So basically, as the machine is going, you're seeing the images coming through.
Exactly.
And you're making that call right then and there.
Correct. And so I'm seeing it on their screen, but then it also gets sent to my phone right away through like an app, like AI kind of a thing, which a lot of places are using these days. Mm-hmm. So I can scan through the images. I can change the views and things in order to accurately figure out what's going on. Mm-hmm. So if I know that it's a bleed, then I'm already thinking, okay, obviously we're not going to be doing the blocked pipes pathway. We're doing a different pathway. And the first thing I'm going to be thinking is, where are the blood pressure agents? Where are the blood pressure medications? We need to get the pressure down.
That's important to know. You're trying to drive the blood pressure down because the assumption, I'm assuming, is that it burst because the pressure was too high. Maybe?
Yes. So a lot of bleeds are caused by high blood pressure. That's true. However, even if you don't have high blood pressure, in the setting of a bleed, a lot of people have high blood pressure because, as you can imagine, that area of the brain where there's, a leak or a busted pipe, the brain's still going to try to get nutrition. So the body's trying to get enough nutrition to that area, but it just can't get it to the right area because it doesn't have the right paths. So it spikes up the blood pressure in order to try to perfuse or give enough blood flow to those areas. So it's an effect of the bleed also.
Wow. So the bleed itself is driving up the blood pressure so it can get more nutrients into the brain, which is making the situation worse, and you're caught in this catch cycle. That's interesting. Okay.
So bleeds or hemorrhagic strokes, is the appropriate term to call them, have always been kind of like the stepchild of strokes.
Okay. Do tell.
So, there's been so much research and so many things that have been done in terms of ischemic strokes or the ones that are like the blocked pipe. But with hemorrhagic strokes, we haven't had nearly as much research that's been done in terms of interventions. In terms of timeframes, we don't really have a lot of those same timeframes or protocols in place, which is now changing. It's something that in the past couple years has been a huge thing in the stroke world.
Okay, that's great.
Yeah. So now we're trying to do similar things like we do with ischemic stroke. So a time to lowering the blood pressure, basically. So time to ordering the blood pressure medication, time to that medication being actually given to the patient, using those kind of times as goals for institutions, because those are the things that make the biggest difference in outcomes.
That's amazing. So now I have a bunch of questions, but my next question, I guess, really is like for people to know, you have a burst pipe or you have a hemorrhagic stroke. What is it that needs to happen? Do they need surgery at that next stage? Do they need something else? Is there some other way to kind of block the vessel? And then the second question, you can kind of integrate this however you wish, is I remember a lot when I was actually in my master's and then, in going into medicine, there was a lot of people doing, and they still in many places were doing this, they were doing a lot of cooling protocols to help preserve the brain and things like that. And what I'm not hearing now is that no longer a thing that people do, or is it still a tool in the kit, or how does it fit into that?
So cooling the brain is still a thing, but it's not. The applications of it are not as many as they used to be.
Okay.
So we used to use it in a lot of cardiac arrest cases or when somebody's heart stops. And part of those protocols, which has not all gone away, but there have been a lot of changes there, less use of it. And in the kind of bleed world, it would apply because you're trying to get the pressures down. If the pressure in the head is too high, it's one of the tools in your toolkit to bring it down.
Okay.
But that's not going to be most of your cases. There are only a few cases that you're going to see
where that might be effective.
That you would go to that length.
Okay. And so just so people know, and you correct me if I'm wrong, we used to cool the body and the brain to help preserve brain damaged tissue when this would happen, because it would minimize the amount of damage. Is that correct? Did I learn that incorrectly?
Well, I mean, in the traumatic brain injury world and things, that is more a setting that you use cooling.
Okay.
So, but I guess it is in any brain injury, it is something that you can always think about.
Okay.
To bring down the kind of metabolic demand, maybe is how you would put it, of the brain.
But the shift now is the primary focus is on driving down the blood pressure in the case of the hemorrhagic stroke. And like you said, just unclogging the pipe as fast as you can so that the person now is perfusing again. Perfusing meaning they're getting the nutrients they need. Yeah.
So driving down the blood pressure is going to be number one, absolutely. The other thing that you have to do urgently in a case of a bleed is reverse a blood thinner if it's appropriate. If they are on a blood thinner and you know that, and you know when their last dose was, or even if you don't, you have protocols for that, you have to put the reversal in to try to help prevent the bleed from expanding, which is one of the biggest predictors of poorer outcome.
Wow. Okay. This is great information, especially for me, because I'm getting a refresher and all this stuff too. I want to make sure I understand all these times well, because we talked about. I don't know if you mentioned about the timing to thrombectomy and
yes, I forgot to go back to that part. Yes,
so
sorry.
No, that's okay. Let's talk about that a little bit, because I want the people to know, like, okay, from the moment this all happens, if they witness the episode in front, they have a certain period of time to get back. And I remember when I was going through medical school, it used to be around 3 hours was the kind of the magic number, but I'm sure that number has changed.
Very much changed.
Yeah.
So when thrombectomies first became a thing, the time frames were pretty short. Like you remember.
Yeah.
There were like 6-hour windows and things around that nature. Now we're for 24 hours.
Okay.
There are even exceptions where we would even go beyond that.
Okay.
So say it's somebody that we don't know when they were last okay, and we're trying to see if we could help them anyways. There are some tools we can use, meaning certain imaging tools we can use to see if they might still be a candidate for intervention. The idea is that we've been pushing the time more and more, and so we're trying to make sure that we're not doing more harm by taking people who shouldn't be going when it might be too late. But so far, we keep running into actually that works, and actually that works. Now that we have people that are doing thrombectomies all the time, so they have a lot more experience, and so the outcomes are a lot better. The devices are a lot better. So that's really changed the thrombectomy world, so to speak.
That's amazing. Okay. And so when do you use interventions, meaning someone's going in to go grab the clot or blow it out with a balloon or whatever it is they may use, versus I'm going to give you some medication that's just going to dissolve the clot?
Ooh, that's an interesting one, because as of right now, you use both.
Okay.
If they qualify. So if they
both.
have enough deficits, meaning enough problems from this acute event, and they have a clot that we're able to get at with the procedure, then we would do both of those things together. There are some studies that are ongoing to try to see if that might not be the case, if we should take people to thrombectomy and prioritize that, and then skip the thrombolytic or the clot busting drug. That hasn't, we don't have any data on that yet to say that we should be doing that. And you have to keep in mind that a lot of places don't have providers that can do these procedures. You have to be a certain type of hospital that can do them. So a lot of these patients are coming from other places too.
And so with the worry of how long and the time is brain problem,
exactly,
then you have to give them, you want to be able to give them something to give them the best chance possible.
Exactly. So in the meantime, we can do the clot busting drug, and it's not going to delay the procedure.
Yeah, that's a tough problem, but great having those tools now that are around. And so now, like at this point in time, let's say you do all these interventions, the person is showing signs they're getting a little bit better. Are they doing this on the general floor? Are they doing this in the intensive care unit? Like, what happens next? Like, because last we left the story was the moment that they're in the CT scanner, you're witnessing this happen in live time, and then we send them off for the interventions. But then afterwards, do they just go home? I doubt that. Right.
Yeah, they don't quite just go home,
right.
But so if they get a thrombectomy, then they will come to the ICU to be monitored closely after the procedure, make sure no complications and whatnot. If they did not get an intervention, or if they got the clot busting drug, they would also come to the ICU. But if they didn't get either of those interventions, it depends on the size of the stroke.
Okay.
So if it's a large stroke and I'm worried that stroke area is going to have swelling or bruising is how I describe it to patients. It's like a bruise, but the
bruise inside of a box.
Exactly. Inside of a really hard container that can't expand. Then I have to watch them in the ICU until I know that their swelling isn't going to cause too many problems,
right.
Or if it does, that we handle it right away.
Right. Okay. And so then that's when they really meet Dr. Julianne Hall, and that's when you are guiding them through all those next steps and the families too.
Yes. I mean, so we're kind of there the entire way because we're in the scanner, we're at the bay with them,
that's
in
true.
the scanner with
right.
them. Then we upstairs in the ICU with them. I mean, sometimes it's our colleagues and things, but there is a lot of continuity there. But yes, that's where these big conversations come in.
That's amazing. And I know that for you, that's a big part of what really motivates you in the work that you do. Is that right?
Yeah. So the reason why that motivates me so much is because my family was a great example of the type of family that just didn't necessarily have the same kinds of goals or things that they would want done that other people might. So, for example, my mother was always a DNR code status, like a do not resuscitate. So if her heart were to stop, she didn't want it restarted. And that was always the case. It wasn't like she was really, really sick and then she became that code status. And so she also had a lot of other wishes where she wouldn't want a lot of things done to her. And it really stood out to me that in training, I saw some really, really good and sometimes not as good examples of where providers would be trying to have these conversations with families. And in some cases, they did what I thought was a really amazing job of explaining what the options were, explaining what the risks and the benefits were, and then, helping them to come to their conclusion of what made the most sense. And then in some cases, I saw a little bit more of a paternalistic kind of practice where I felt like patients were kind of being told, you should do this instead of these are the options. And there isn't a wrong answer. There's or a right answer, I should say. For one person, this might be the best thing for them. And then for another person, something else would be. And sometimes we want patients to do what we think they should do.
Right.
It's a really hard thing to tease apart. It's hard to hold back. Because you're like, well, but you could get so much better, or whatever our thoughts are, because we know all the information, but their opinions and their beliefs and their life story is going to influence all of the things that they're going to want or not want. So my goal is to make sure that we're doing what you want and giving you the information so I can help us do what you want. Because, who cares if I think it's a good plan? It's not my body.
That's right.
It's your body. It's your life and your family.
Yeah. And that's a wonderful attitude to have for this, because it's truly, you're absolutely right. And I'm sure your patients very much appreciate that.
It is,
or at least their families, because some of the patients might not be able to respond. But
Yeah. Actually, when a patient comes in really, really sick, and I never really get to meet them, because they're just that sick, the family often becomes my patient. They're like the main people that I'm working with and talking to, and just the most important job I consider my most important job, making sure that I'm having those conversations and having them in a way that is compassionate and in a way that that people are understanding the decisions they're making and not being misinformed or confused or being rushed into things. Yeah.
That's amazing. That's amazing. I know that we could definitely absolutely talk about all of this for a far longer period of time. And I think I would love to get you back here at some point to kind of talk about the journey that people go through. And we can walk through it in the ICU and talk about all those things and elements together.
Will you come to the ICU?
I would love to. I would absolutely love to. It'd be my
I'd love
honor
to have
and privilege.
you.
Yeah.
That'd be fun.
Yeah, I think we should definitely do that. I'll check with Yasmina, our producer. Are we good with that? Yes, I think so. Awesome. But I cannot thank you enough, Dr. Hall, Dr. Julianne, for being here. You've been a phenomenal guest. I know that the entire community of Arlington Heights and the whole surrounding region of the northwest suburbs of Chicago are blessed to have you here. And we are blessed at IMG to have you as well. This was great. I learned a tremendous amount. And if I learned a tremendous amount, I have to believe that our audience did too. So,
well, Sammy, I had a wonderful time, and you were amazing. It's hard to talk about yourself and have this kind of environment, but you are so good at it. So thank you for inviting me. I really do appreciate that.
My absolute pleasure. You are a forever welcome guest. The door is open anytime here on the IMG podcast. Well, everyone, that wraps up today's episode of the Intent Medical Group podcast. A big thank you to Dr. Julianne Hall for taking the time to join us and share such valuable knowledge. If you enjoyed this conversation, be sure to follow or subscribe so you never miss an episode. And if you're new to our podcast, welcome again. We're glad to have you here. You can learn more about our providers and services at intentmedicalgroup.com, and don't forget to connect with our social media. We'd love to hear from you for sure. Drop us a comment and send us a message on social. Thanks again. We'll see you next time.